Becky, thank you very much for this very friendly introduction, and it's for sure a very great honor to be here. I started with this slide because this is very current everywhere, but particularly in Switzerland. On Sunday, while I was preparing the talk, I got an email from the CEO to tell that from today there will be no permission to go to any meeting at any place in the world. And I negotiate on Monday and say I'm not going to a meeting, but there is a very important lecture that I need to do for Pitt for this association that I cannot miss. So I got the authorization for this, but not to attend the meetings. An interesting challenge for me to be here, but not be here. So please, not too many photos, Henry, now. I'm going to do that. All right. So, all right. Well, I know we give this lecture only once, so why not just to take pictures? So that's okay. And that's what was coming here. You can see that this is in German, but it's easy to understand. That came here from the CEO. And here, Teilnahme am Kongressen, so participation at Congress in or outside of the country. You told me that is not permitted. No. All right. So again, it's a very great honor to be here to give this quality oration for several reasons. For the AHPBA, number one, which I was a long time ago in the initial group here, when I remember we were, I think, 25 or in the mid-90s. So that was a complete different meeting. So my heart is certainly here for that. For Pitt, that I think the first time I saw you was a fellow in Toronto, where an invited professor or something. So I was very impressed to have this very prestigious professor coming from the US. We interacted on many occasions with the IHPBA and many other things. And the third is to speak about quality. This is a boring topic for many surgeons who like to operate, to like to do things. They don't think they can make a career yet. This is probably the most important topic for society and for us and for patients, of course. So I think it's courageous to have a lecture dedicated to quality. So that's a very honor for me to do that, and I need to learn to mention to do it here. Okay, so the title is basically the summary or the conclusion, so I would start with a more exciting title, or I mean simple. We will talk about quality and how we assess quality for different angles. Complex topic that will take a lot of time, so I will give a little bit our perspective from the group I'm working with on this topic. I divided the talk in 4 parts, a little bit to speak about quality, endpoints, what do we want to measure, this benchmarking topic here, how we should look at our results, and come maybe with a relatively new information in terms of the value or the importance of operating in difficult cases and not on the benchmark or the so-called easy cases. So if we go back, this is what everybody learn when we do surgery or anything: please do not hurt. And this is something we repeat all the time to our residents because we know that sometimes we do hurt. And this is clearly a topic that is to be part of every conversation and teaching we have in the hospital. So what is quality? That's again a very interesting word, how we define that here. And if we go to some dictionary about quality, basically is to have a standard that we know is good, and then you have something does it is good or bad compared to this standard. That's about what the Oxford Dictionary is telling us. Yet we, all of us know, even if you use the Da Vinci or the laparoscopy, that we deliberately inflict harm to our patients. So if we were just going to this definition, then we should just stop doing any kind of surgery. So we need somewhat an objective definition or something we can use that could be accepted everywhere. Right? It's difficult. For many people, this city, Zurich, was the best city to live for Mercer for over 12 years. But many will argue that Miami is a much better place to live. So we have here a problem of objectivity, of perception from patient and everything. And here I would like to quote Goethe here that said that no two people see the world exactly alike. Even one and the same person won't always maintain the same view and judgment. So the difference between people, different about time, we know emotion, everything, that change a lot. And One, just to quote this study that we did in '96, many years ago, done by Christine Hunt. She was a hepatologist here, who wanted to correlate complication, what happened, and quality of life in the patient. And I just show this example to show that sometimes there's absolutely no correlation. We'll have here patient 1 is a young patient, primary sclerosing cholangitis here, low MELD, but he needs a liver transplant. You have another one who is at the limit of being transplanted, very sick, with a lot of comorbidities. They both of these patients have liver transplant expected. The first one has not many complications. He's young, he's doing well. He has only one grade 1 complication, which is a wound infect. Otherwise, from surgical perspective, perfect case. But he has this problem at the end. The next one, also to be expected, 3 weeks in the intensive care unit, long time in the hospital, on dialysis for a long time. If we calculate his complication index, he's very close to being dead in this situation. He has very serious complication requiring to go to the intensive care unit. And at 1 year, this patient is very happy, he'll enjoy life, and the other one complains all the time, is not working, and is very disappointed with what's going on. So there is a clear discrepancy in perception of patient about quality. Now, if we look also at the big pictures here, we are a little bit not very proud of what we are doing. If we look here at the cause of death here, globally here, and we can see that us, postoperative complication from patient, rank number 3. We kill more people than COPD, etc. Certainly the coronavirus is very far away from what we are doing in terms of surgery. So we are certainly causing problems. We have to recognize that. Everybody do difficult case knows, and this is a challenge for us, probably in the beginning of our career, because we very often assume this is because of us. Certainly not, but we are hurting many patients, and here this is more than 4 million people will die worldwide because of surgery. This is pretty impressive pictures. If we look also from a big perspective in terms also of the economy, if we look like in the United States, here the life lost, we can see the traffic is pretty bad. The other one, which are often on the headline, I mean, certainly cause death, but not that, but the healthcare system is by far the number 1 killer in this country, which is not different than many other countries. Let's go back now to the surgeon, acknowledging that patient may perceive things differently that we do, yet we have to do our work and assess what we are doing here in terms of complication, which is basically a chance for the best course we can have. Anything outside of that is somewhat a complication, and then we have always this balance between harm and quality. Now here I just look at a paper that I quote very often, some time ago, but I don't think it's very different. We were looking at what do we publish in our literature here. Then we hear again, not very proud. Here this is meta-analysis of many articles published in top journals. And at that time, he was looking at whether we have follow-up information in those papers. Only 20% of paper give any information about the follow-up. The definition speak about complication. Only a third will explain to the reader what's a complication. Are they serious or not? Or is that defined? Only 20%. And then, of course, we need to do the risk factor. A third also give risk factors. So the people who look at our literature from outside have the right to be critical in terms of what we are reporting. I have this example here that I show here. Dr. Trede was a pioneer of Whipple operation in the 90s, reported 20% morbidity. The other study is a study that we did together with Johns Hopkins over 3 years, 10 years ago, of more than 600 patients, and we have 60% complications. Of course, here we don't speak the same language. The work that we did on Johns Hopkins was to test the complications, so we were looking at every deviation. For Mr. Trede, only if the patient was going to the operating room back was a complication. So, if you just use these figures, you learn absolutely nothing. Even today, I will not go here, you have many definitions of fistulas. There's some agreement, most will use, I guess, the Johns Hopkins, but there is disagreement. But every time you need the drain to measure it, but many patients have no drain today. So how do we define this fistula? So we have really a problem of terminology, and we need to search for some objectivity. Here, what is objective? Here are two people. I think Chuck is not in the room here. We have conversation yesterday about the politics. My son, who is born in this country, an American, I can disclose, is a very top supporter for the first one here. I know that many don't share this opinion, but others will maybe have the other one. So who has the truth? What is objective? Of course, I will not debate on this here, and I have not much right to do it. But if we go back to medicine, you have a patient has a postoperative pneumonia. Could be that, antibiotic and home, or could be this patient who is in the intensive care unit intubated. Most of the time, it's very difficult to know what is really reported in a paper. Now, I will not go to all the different endpoints that were discussed, but I will continue to go a bit on how we can objectively compare quality in this. So here I would just mention, because of Henry Pitt and this country, there's a very big effort done in this direction with the ACS, American College of Surgeons, NSQIP here. They were pioneers a long time ago. It was mandatory for the VA administration to report the complication, and just by doing this, there was an effect, a positive effect by recording, by observing that you have some correction about this. So there is now, it's widely used in different countries, many patients. There is statistician working on risk adjustment here, and the follow-up is 30 days, which may be a bit short, but this is the follow-up. And you have, if you go on the system, many are using it. There is also paper showing whether it's accurate or not, that you can, for specific patient, calculate what's the risk here. The difference, which what I want to show here, doesn't mean we cannot use the NSQIP, is that here we compare to the average of what data is here, and benchmark might be a little bit different, and I will talk about it. So I'm coming now to the topic of benchmark. We will have, let's say, a center who has this course for procedures, another one this course, and the third one this course for a procedure, whatever endpoint we use. And now the question, there is clearly a gap, and how do we know which center is the best? And many times you may find that the number 3 is by far the best center than the other one. So how can we objectively capture this that is not biased by self-reporting, which is one of our problems in surgery? The number one that we postulate is that we do not want to compare to the average. We need to compare to something better than the average. So what's benchmark? In the market, it's pretty clear. For the cell phone, this is the benchmark, and the other one try to mimic or do it better. How it is in sport? In sport, there is also some benchmark, or people are considering it better than others, but it's clear that in medicine, it's wrong to go to only one fellow or one center. That we cannot do it. It has to go to a series of top good people. You get what they can do the best, and then we can compare our center, ourselves, or whatever, to what they are doing in this setting. So comparison to somewhat to the top shot. That's when I would like now to present for a few years. We have developed that, a group of people which combine epidemiologists and different people in that to try to come with some novel idea of something that is unbiased in terms of benchmarking that can be applied to centers, to patients, to country, again, in an objective way. So the goal is to identify the best achievable result that we can do. So the first is to, if we want, I will show some procedures, and the work is going on for some procedures. So we decided to go to some sort of the ideal case. Number one, you need to go to a center who do a lot of cases, so representative sample. Then you need to measure the right things. You need to measure something that's relevant, that you can correct. For example, if you do liver surgery and you report on transaminase level, which I did in the past, like many others, we know today is completely irrelevant, and this randomized trial or whatever is absolutely no value. So we need endpoints that have a meaning. We talk about the follow-up. Very important to have this follow-up. We need to respect and know what is the follow-up needed to have some relevant information about the procedures in this and the patient selection. So sample, we go to high-volume center. They are more likely to be good. Everybody knows today that volume is not equal quality, but low volume is usually equals not top quality. The outcome indicator, that's also something that we are moving from. This is a morbidity. This is probably the easiest to measure objectively here. Mortality need to be here, but fortunately is no longer a big marker. The follow-up, we know discharge is too short. It should be between 3 months and 12 months. And I will show from some of the study that, for example, for liver resection, 3 months is probably okay. For Whipple, it has to go probably to 6 months. And liver transplant absolutely report 1 year. And I will show you some data that any report shorter than 1 year is biased. And patient selection, low risk. So this is very selective. We go here in a population to take the ideal scenario. And the indicator from outcome and dimension should be relevant, validated, standardized, that you can reproduce and that you can improve. So there is a meaning for this. So for example, what can we measure? Well, time of surgery, this is somewhat relevant, whether you need blood, the intensive care unit, if you need dialysis, are relevant parameters. Mortality need to be here, and morbidity, we can use a grading of complication, and we can use an overall index, like the complication complex index that we can use also, for example, to have an overall view of the morbidity. Now, that was done in a close collaboration. We're lucky, very lucky in Zurich to have a young fellow from epidemiology who took the chair, who was 7 years also at Johns Hopkins, came back. And together, because he wanted to help us, we wanted to make sure we do some sort of the right thing, that we came with this kind of methodology. So the idea is to take a number of centers. We want procedure X, let's say liver transplant or pancreas surgery. We select the center with a high volume or the biggest in the centers. And then here I just show as an example the complication index. And here that's the different centers that will report at 3 months this different complication index. So how do we define what's the best? So here we can plot that with the extreme, go from 20 to 42, the median, and then we decided to take the 75 percentile of those centers. So basically we eliminate the top poorest centers, the 25%, and we keep the other one, and that's what we call the benchmark value, assuming this is a value that any center or patient should be able to reach. So now I give you some concrete example of study that have been done. Here was done by Clavien who was originally from Luxembourg, sent to my center from Belgium, spent some time, did this work, and now he is back in France with one of the fellow trained with us. And the question was liver transplant. So we wanted a procedure that is associated with significant morbidity, where there is really not much data in terms of benchmark. It's very complicated to understand where we are outside of mortality. So first, we took 17, the 17 biggest or largest transplant center in many countries on 3 continents, and we wanted a minimum volume. Arbitrarily, we decided 50 transplant per year and a minute, and we have the risk factor. So we wanted the good case on liver transplant. And that's a selection we did. I will not go into many detail. In transplant, you have a patient and you have a donor. So on the donor, we take only brain death, not the higher risk, no living donor, whole graft, and the recipient, you can see, for those who are in transplant, MELD of 20, so that's pretty low-risk cases, no portal vein thrombosis, no retransplant, etc. So the case, if you call on a Saturday evening to do the transplant, you smile because probably things will go well. And we even we use a matching score to make sure that we were on the good side. First data we have a total of 7,500 transplants from these centers. 2,000 were benchmark, about a third. And when we did the Whipple, it's about the same. About a third of the case are benchmark cases or easy cases. 2/3 are not. So here, this is the follow-up. The first questions that we can address here is, what follow-up? So here we have again the CCI, but we can use other factors, and we can see a discharge is 30, and it go up to 1 year to 42, and then it's relatively a plateau. So for the simple graph that we have here, then we can recommend that if you want to have a meaningful, you need 1 year report at 1 year, your data on liver transplants that will make sense because we probably capture most of the problem. I just give you here the data, the duration of surgery, which was calculated, variation between Japan, Europe, etc., was 6 hours. Blood transfusion, 3 units, 4 days in intensive care unit, and the most difficult to evaluate because different policy was the length of stay, which altogether was 18 days. Now we could go here by complication, and you can see here we have discharge, 3 months, 6 months, 12 months, and we can plot here whatever we want, any complication. Basically, it is known, this is very rare that a liver transplant has 0 complication. Most of them will have something. More than grade 3, so serious complication, 60%, and biliary complication, you can see even increase, and this is not DCD, this is DBD, from 20 to 28% between 6 months and 1 year. And this is well known by many transplant surgeons that this happened here. And the mortality also changed 10 years at 1 year, which is very low initially. So that's objective data collected in these centers. So, of course, low mortality today in these cases, but a high morbidity. I show you, I will interpret that, the next study that was done by Patricia Sanchez. She just came back. She was a fellow for 3 years with us, came from Barcelona, and did a very, very good job, and took the lead on this study, which the question was, what are the benchmark of duodenopancreatectomy in this? And you can see here many centers participate. In fact, 23 centers were involved. I will not go in detail. Many centers in Europe did participate. We contacted them personally. They were selected based on the size of the program, meaning the 2 or the 1 single more larger program. We have 3 in Japan, not many, but 3 we had in Japan from the large centers. And we're very happy to have in this country many top centers who did participate. You can see that most of the top pancreas center decided to help, which was very important to get some meaningful data. So the first here, we have to decide what is an ideal case for duodenopancreatectomy here. Resectable disease, no portal vein or arterial reconstruction, so we did no major abdominal surgery before, and no comorbidities. We know it's important. They are well defined. If there's significant cardiac disease, they are not benchmark cases. Data here, again, not very far from liver transplant. We have a total of 6,000 cases, and about a third were benchmark cases. 2/3 of the patients that were operated were not benchmark cases. I go also, for time reason, directly to the result of this. So this is, again, 75% of the data from the centers. Time of surgery, 7.5 hours. Many people will say, well, if you're a good surgeon, your Whipple is done in 3 hours. That's benchmark cases altogether. No blood transfusion, 1 day in the ICU and 2 weeks in the hospital, data from this international data. And here we have, again, the complication or the morbidity. Also, most of them have some sort of complication. A third more than grade 3A. You can see that the fistula is at 19%. We did not differentiate. We did subgroup, but we're not present here for soft versus hard pancreas. So here, the definition did not include intraoperative data. In-hospital mortality, 1.6%. 1 year readmission, 21%. And here, of course, the center, like this country, who discharge very early, have a higher readmission rate than those who may discharge later on. So now we did different procedures. I just summarized on this slide. Another group, which is very good, they've used somewhat the same methodology, and for the first time, we can compare an esophagectomy with a living donor, with a liver transplant, with a pancreas, and last year was even presented the ALPS procedures, what are the best results we can have in the ideal cases. For the ALPS, it was colorectal, young patient, etc. And here we can compare this. Has that a value? I think it has a value, and it has, when I will come a bit to cost, because there has an impact on that. So we can see if we took any complication, that liver transplant is number 1. We can compare to living donor. Serious complication, more than 3 years, we can see that liver transplant and ALPS are ahead, etc. The CCI, this is the cumulative morbidity here at 3 months. We have also interesting information here to see that ALPS and pancreas not very different, and mortality need to be reported, and you can read here from this benchmark following the same methodology for the first time where we are. Now we decided to go another but highly discussed procedure, which is periileal cholangiocarcinoma. Many people from single center with incredible good data sometimes. So here we decided, and we did that with together with the biggest group in Nagoya and a group in Germany, Mr. Auke Lang and us. We initiated that, and here we decided to have minimum of 15 cases per year. It's a relatively a lot. And when you ask people here, they all will tell, well, I do 30 perihialia, no problem. When they look at the data, they have 4 per year. So there is differences here. So we wanted to have really this major hepatectomy because that's the standard of care. No vascular invasion here. We made an exception for Germany because they resect the portal vein based on the work for Peter Neuhaus routinely, whether there is invasion or not. So we will include them. We do a separate analysis, no significant morbidity, etc. So this work is just going on right now, and we hope to have some data. And you can see here, that's the major success. We have many, so many in Asia now. They have a lot of perihilar cholangiocarcinoma. So we have many centers in there, a fair number in Europe, and a fair number also in this country. So we collect this data now here, and it's one of the fellow who do the machine perfusion with us for the time who is running this, and then we will know maybe open a little bit more about this disease. Now, how do you use this? So it's nice to have this benchmark. Is that an academic exercise, or that can be useful for us as a surgeon, as patients? Is that a tool that was an idea to work with our administration? Many of you here who are head of departments, we are given data that are wrong, misleading. They try to believe we are very costly. These data help us now to have in our hand tools where we can talk to all these people who did MBA, learning the same thing, and try to mislead us. With this, we have a tool that we are using. So I will come to that in the few last minutes here. So how to use it? Well, that's first of all very simple. If you have centers here in a country or whatever, you can look here where you are. And if you have the benchmark value here, these 3 centers, they need to look at the data. Something is not right. They are outside of this. We are using that also for individual centers where now, that's what we do in Zurich, every patient has the benchmark. We look at CCI, and every patient who is above the benchmark that we expect for Whipple, they have to be discussed in the MMN. Most of the time, they are not benchmark cases. So that's okay. I mean, we can do it. But if they are, then we know something is wrong, and it gives some objective way to look at this to select patient for the MMN. Now I will come maybe to the main message of this talk, or something that is maybe novel, at least it was for us, even if intuitively thinking about it is not. So this is here, as an example, the raw data from the Whipple. We have the 23 centers. That's the total number of cases that they were presenting here, 900 cases. Minimum was 50 cases per year. And in blue are the benchmark cases. So there are very significant difference among centers, whether they do difficult cases or benchmark cases. Take 2 centers here, and that do about the same number. Part of that, 2 centers here, one has 12% of benchmark cases, so they do very difficult cases. They rarely benchmark cases, and the other one do almost exclusively benchmarks, 3/4 of the case. Complete different centers that here we can just with that highlight immediately. We know whether they do difficult or not difficult case in a very simple and visual way. Observation, the center who do a lot of difficult cases has 3% fistula. The other one, 11% fistula. So that tells us, okay, that's interesting. That's interesting that those who do difficult cases have better result overall. And we observed that maybe a learning curve effect. Intuitively, you do difficult cases, your skill is maybe a little bit better, the ICU is better in seeing complications, many factors that can permit to have less problems. But we have another one here, these largest centers, very high with 900 cases from this country, in fact. Here, they have a lot of difficult cases, few benchmarks, but they have a fistula rate which is in between the other one. That's an example because we found the same thing in liver transplant for different parameters here. And here I will show you that's what we call a bit the break point, the breakdown point where maybe too many cases may not be the best when you do this kind of surgery. So basically the novel finding here is that more benchmark cases, you have inferior outcome. So treating more complex cases, if I'm a patient, I know that this center most likely has better result than the other centers, providing, even if this number of cases is similar. 2 examples here, I mean, I will not go in detail. Here is the fistula, you can see here. This is the postoperative pancreatic fistula, so the serious one, versus the proportion of benchmark cases. Pretty good curve, pretty convincing curve among the centers that more difficult case, less fistula you have. In liver transplant, one Achilles heel is biliary complication. Same observation. Here, more benchmark cases you do, more complication, more biliary complication you have. And every time we test this, we found a very interesting correlation, which is somewhat a novel way of evaluating centers from this perspective. Now, I come to this graph that in a theory way may explain a little bit what's going on in terms of outcome. Here you have outcome, whatever you measure here, could be also oncological outcome long term, and the volume. This is well known that to a low volume your results are not very good, and then you improve, and then you have this point, which is basically the top of the learning curve. So that's here clearly the learning curve. And then after some time, could be many cases, this is observed in several large studies, one done in pancreas in France and others, that suddenly very high center, they don't have the same result as the other one. And here this is what we call the breaking point. At that time, it can be prevented, but this is very easy. There's too many cases that they have to see. Maybe this is not the top people who take care. They don't have the resources. There are many explanation, but this is an observation that we can see. So if we summarize a bit that here, we can see that between a high number of benchmark versus low number, there's a risk-taking. That may be done on purpose, you turn down, or that's what you have referral centers in this. This is volume independent. It has an influence on overall outcome. So the benchmark cases is now considered as a performance metric. When you have just this ratio, this is one of the new performance. I just wanted to show here the last work that was done, related plus minus to this. I will come back to the benchmarks done by Roxanne Steiger, who's doing now a colorectal fellowship in London, who spent some time with us. And basically the question that was coming was to see, can we predict early on in the course whether we have a bad course? It is surgical complication, medical complication, or type of the complication play a role when you have on what will happen later on. So she was looking at different procedures here in a relatively large database. So the idea is indeed, in the first week, you could look at what a complication you have and if they may lead to, and the definition was here more than 3A, which is a CCI of about 38 in this setting. I just show you the result of that, because I think it's interesting data that should be presented at the European Surgical if the meeting takes place. That's another question. So here we have one complication, for example, a pneumonia, plus another one, could be a rare operation. Those are designed predicting at 3 months or 6 months a very bad course. And I just show you the result also for time here. The type, meaning do you have a GI bleeding, an infection, pneumonia, play no role. We could not detect anything here that would predict. And also surgical versus medical complication here did not predict, but what was predicting is basically any complication of any type that occur early on is associated with a 61% increase in later morbidity, and also the cumulative morbidity was very important here. After 1 week, there was a very dramatic increase. If you have a CCI of 30, of more than 40, then you have a double chance of having problems later on. So that was another information here that complement a bit also the benchmark study. So we have now some warning events that could help us to act and maybe prevent the failure to rescue other things that can happen in the course. I finish here the last couple of minutes here about cost, because that was pretty logical. There's a study that was done here a few years ago that shows here that complication is the single most important factor, cost more than comorbidities, anything else, by measuring that. So it means that we could use that to calculate the cost. And that's the work, again, that Dr. Steiger did here on this. Try to use the complication index, which is accumulation of all complication, and to find there's a formula that could be close to whatever is the cost, which would be very useful for us, and it gives us a tool to discuss with our administration with this. First of all, there was a correlation to be expected between the high of CCR, postoperative complication, and cost here. And the formula told us that every 10 points on the CR was a 14% increase in cost, irrespective of the procedure. There were 7 procedures that were looked at. As an example here, and we are using that, we are testing that now. If we take a type of surgery here with the baseline cost, which is it be adjusted for country, so it's not dependent of the country. The CCI, when we can add to the cost, and we found the age, which was a good surrogate marker of comorbidities here, too complicated when something simple, that could help us to go to the cost. Whipple operation here, baseline will be $38,000 here. Let's say we have CCI of 30, which is in the benchmark area. That will add 15,000, patient 65, 4,000, and we have a total cost of 58. And now every time we look at our data, very easily calculated here, and we compare to what the administration is telling us. And we have some tool here to argue with the cost and the resources, etc., which is also important. Okay, I come to the taking home message from this lecture. I think the benchmark, the way we look, is to compare to the best. We need to accept there is some room. Can be better than the best, that's okay, but that's what it is. We need to have gaps that we understand and we can correct in different areas to do better. We always try to work an unbiased way. We cannot rely on us. We are surgeons, we evaluated everything we report. It's always suspicious in some way. And we found also here that if you have a high number of high-risk cases, low benchmark cases, you're most likely to be a center of excellence and offer a better service. So this is a tool, of course, for improvement. Very important in innovation here. I think it's when we go with something new, you have to convince whoever that you are not hurting patients, and I think this is very important here, and in quality control. As the credit of many people here, you can see who have worked in different parts, and some did a PhD. Now we have 3 who did PhD in this topic, and Milo Puran is my partner of epidemiology, who with him will not have done anything basically on all this outcome research we are doing. So Betty and Henry, thank you very much for the honor of giving this talk here. I wanted also briefly to acknowledge 2 other people here because I worked with them a long time, which is Steve Strasberg, when I started all this complication story when I was a fellow in his lab, and Jeff Barker, I don't know if he's here, but he has been involved over the last years on all this benchmark and advisor and co-authors of what we're doing. So thank you very much for the honor of the talk. Thanks.